Hello, welcome again. I'm back to discuss on approach to a child with rectal bleeding. Just as an introduction, the large intestine is said to be a part of an intestine which is found distal to the ligament of Teres. It begins as the cecum and also includes the appendix, colon, rectum, and the anus. The primary function of large intestine is to dehydrate and store fecal material. And to define melena and hematochezia, which is a passage of blood mixed stool through the stool. Melena is black, tarry stool, which suggests blood proximal to ileocecal valve, whereas hematochezia is a bright red blood per rectum. This generally indicates a colonic site of bleeding or distal site of bleeding, but occasionally bright red blood in the stool may originate from small intestine as a result of rapid GI transit, or if there is massive hemorrhage from small intestine, the transit is so rapid and we might see bright red blood. Let us discuss the differential for rectal bleeding based on the age of the child to make it more simpler. So when we start from neonate to 3 months, the possible differential diagnosis are: the first one is swallowed maternal blood. This is mainly from the tip of the breast and also most probably during delivery. If it is due to swallowing from the tip of maternal breast, there might be feeding difficulties, painful feeding, and cracked nipples. The other differential can be coagulopathy, which is vitamin K deficiency bleeding, maternal medications such as warfarin, and hereditary factors. Maybe bacterial enteritis or sepsis can also cause GI bleeding, and milk protein allergies, blood mixed with stool, recent change of feed, and vomiting might show milk protein allergies. Anal fissure can occur. In this case, bright red blood that strikes the stool or causes spot of blood in the nappy tear as a mucocutaneous line. And gastric ulcer, which is not as such common, can occur in stress, especially during the third trimester if the baby is asphyxiated. Asphyxia can damage any organ, including the GI mucosa. So stress during third trimester can cause GI ulcer, and also ingested non-steroidal anti-inflammatory drugs and steroids can cause GI ulcer. Rare cause of rectal bleeding in neonates up to 3 months includes volvulus, necrotizing enterocolitis. Necrotizing enterocolitis actually is common in preterm babies, and HSD or ganglionic megacolon, Meckel's diverticulum, rarely intussusception, and also AV malformation. When we came to infant between 3 months to 18 months, the possible differential diagnosis for rectal bleeding at this age and the key indicators include: we classify them as lower GI source and upper GI source. The lower GI source mainly presents as hematochezia, and the upper GI may present as melena. The lower GI source includes intussusception. Intussusception most likely the cause of lower GI bleeding in infants aged between 6 to 18 months. It presents as colic abdominal pain, which is intermittent in type, vomiting, abdominal mass, and distension, and also you can palpate the mass. Meckel's diverticulum is another possibility. In this case, the bleeding is always painless and it is profuse. Occasionally, it might not be profuse, and most of the time, Meckel's diverticulum is well known for painless rectal bleeding, and it may lead to drop in hemoglobin. Bacterial enteritis sepsis can also cause GI bleeding at any age, and milk protein allergy. In this case, they present with blood mixed with stool, and most of the time they present with recent change of food and also introduction of milk. Anal fissure. In this case, bright red blood that streaks the stool or causes spot of blood in the nappy and the tear at the mucocutaneous line, and the most commonly located dorsally in the midline. Anal fissure is more common in children who have constipation and who strains during passing stool. The other differentials for this group include gangrenous bowel. This might be due to malrotation with volvulus or other cause of volvulus. The other is bleeding polyp, including juvenile polyposis. So any polyp, if it is bleeding, it can cause intermittent painless bleeding. And also if the polyp is lower one, it might protrude intermittently per rectum. The other is, which is a rare one, HSD. HSD mainly if it presents with enterocolites. If it is intervened later or it's not diagnosed earlier, and they may present with enterocolites. In this case, there might be rectal bleeding, and also AV malformation can occur at this age. The upper GI source include esophagitis. In this case, there is pain on feeding and arching back, and gastritis, which can be due to H. pylori, steroid, non-steroidal anti-inflammatory drugs, Zollinger-Ellison syndrome, Crohn's disease, and also other systemic illness. When we came to older children, in this case also we classify as lower GI source and the upper GI source. From the lower GI source, juvenile polyp, the most common cause of lower GI bleeding in children older than 2 years. Intermittent painless bleeding in children more than 2 years is high likely juvenile polyposis. And the other is infectious diarrhea. Profuse diarrhea with bleeding, and the recent antibiotics used can indicate as the presence of infectious diarrhea. Infectious diarrhea can be bacterial or amoebiasis. The other is inflammatory bowel disease. In this case, bleeding is more typical in ulcerative colitis than Crohn's, but can occur in either, typically as a bloody diarrhea, and the diagnosis usually occurs prior to GI bleeds, because there is a lot of manifestation other than GI bleeding in the case of inflammatory bowel disease. The other possible differential at this age include also anal fissures, as we have said above. In this case, as I have said above, history of constipation, the painful defecation or withholding are there. Still, in addition to juvenile polyposis, the most common possibility of GI bleeding include Meckel's diverticulum. Vascular regions, Meckel diverticulum, in this case profuse and herald may lead to drop in hemoglobin. The other is gangrenous bowel, malrotation with volvulus and other causes of volvulus can cause GI bleeding. Rare causes include HSD, enterocolitis. If it is delayed too late and presents with enterocolitis and AV malformation and also intussusception can cause rectal bleeding at this age. But those things are rare. When we came to the upper GI source in older children, esophageal varices from portal hypertension, duodenal ulcer, in this case pain after eating through to back, and also Mallory Wasey tears. This is characterized by retching stream and also alcohol use. But in children, alcohol use is not common, and most of the time, Mallory Wasey tear occurs after a child develops sudden onset of vomiting due to food poisoning or early gastroenteritis. When they present with vomiting, there is retching, and during those time, there will be tears. This causes bleeding, and the bleeding can pass through the stool. Esophagitis is also another differential. It presents with heartburn and a neurological impairment. Gastritis, which might be due to any cause, H. pylori, steroid, non-steroidal anti-inflammatory drugs, and others, can present as rectal bleeding. There are also another classification systems. From this, we can classify rectal bleeding in children as painless and painful rectal bleeding. And also, after we classify as painless and painful, we classify based on the age. Painless less than 3 months include swallowed maternal bleed, vitamin K deficiency bleeding, allergic proctocolitis, gastritis, vascular malformation. And painful less than 3 months include necrotizing enterocolitis. Even though they can't tell us the pain, we feel they have pain or they are in pain. For 3 months to 2 years, the painless rectal bed loss includes mallory waste tears, allergic proctocolitis, Meckel's diverticulum, vascular malformation, polyps, and hemophilia. And the painful one for those between 3 months to 2 years include anal fissure, esophagitis, gastritis, PUD, intussusception, infectious colitis, and others. When we came to laboratory test, first we should have to do complete blood count. In this case, a recent blood might not initially alter the hemoglobin or hematocrit. Otherwise, if it is protracted or recurrent bleeding, there will be a drop in hemoglobin. ASR or CRP may indicate inflammatory bowel disease or sepsis. Coagulation profile is used to rule out a liver disease, a bleeding disorder, or a disseminated intravascular coagulopathy as a cause of rectal bleeding. Liver function test is also used if it's important. Liver enzyme, if there are signs of portal hypertension or chronic liver disease. Stool cultures and Clostridium difficile toxin assay if there are loose stools. Any main things that we should have to remember is H. pylori stool antigen. Those things are done here and there, but H. pylori stool antigen is not recommended as H. pylori because H. pylori is prevalent in the general pediatric population and is not usually associated with morbidity. So it might be fluorozer without causing any problem. And when we do it, if it becomes positive, it might not tell us it is the exact cause of the problem. H. pylori complications are diagnosed endoscopically. So H. pylori stool antigen is not as such useful in pediatric population because it's prevalent in general pediatric population. When we came to imaging, colonoscopy is the best test for significant lower GI bleeding. But in the case of intussusception, ultrasound is the most important and the most confirmatory one. So if we suspect intussusception, we should have to send ultrasound. Otherwise, colonoscopy is overall the best test for significant lower GI bleeding. If a child presents with painless rectal bleeding, we should have to think top on the list as a cause of painless rectal bleeding, a Meckel's diverticulum. So a Meckel scan is the procedure of choice. And also CT angiography may also help localize bleeding for AV malformation. And if the bleeding in the GI tract is obscure, capsule endoscopy may provide diagnosis in some cases. When we see the principle of treatment of rectal bleeding, if there is significant bleeding, we should have to secure 2 large IV lines and re-establish blood volume by rapid infusion of normal saline, and if available at hand, by giving blood transfusion. And significant GI bleeding requires admission for observation and ongoing investigation in the treatment. And the curative treatment depends on the underlying etiology for rectal bleeding. This is all about approach to rectal bleeding in children. Thank you for watching.